The first thing we do is look at the dog walking. We want to assess his gait, and we want to do this from the front, from behind, and also from the sides. We're looking for symmetry, and also that the dog is moving freely and is comfortable. Looking from the side, we're looking to check that the angular velocity of the limbs is the same. So the elbows, the stifles, the carpus, the hocks, shoulders and hips are all moving symmetrically and as they should. We'll do this at a walk, but it's also useful to do it at faster gaits, and we'll often trot patients, and in some patients, depending on what's wrong with them, we might even run them, which might pick up more subtle asymmetries. Looking from the front, the head should be level, and there shouldn't be a head nod, and the limbs should be evenly spaced from the midline. A dog with a forelimb lameness will lift the head during stance phase to reduce weight bearing on the sore leg. In this case, this dog is lame on the right forelimb. From behind, the hips and the hocks should be at the same level. They shouldn't be elevated, and the limbs should be symmetrical. This Labrador is very clearly lame on the left back leg, and his left hock is not sinking to the ground as much as the right hock. This boxer, just one day after total hip replacement, has a more subtle hind limb lameness, but you can see when the video is slowed down that the left hind limb swings forwards a lot quicker than the right, so that the dog is minimizing weight bearing time on the right side. The orthopaedic examination itself should always start with a quick basic physical examination. The trunk and the limbs are palpated for symmetry, feeling for signs of muscle wastage or thickening of joints due to fibrosis. This is easiest done standing over the dog and from behind the dog. The spine can be palpated, pressure can be applied to the spine to detect any signs of spinal pain. The dog should be able to tolerate relatively firm pressure over the entire length of the spine. Pay particular attention to the lumbosacral area in dogs with hind limb lameness, which might relate to a lumbosacral disease. The neck is manipulated up and down and left and right, and this is particularly useful for dogs with a forelimb lameness that might relate to the cervical spine. Most clinicians will start at the toes when examining a limb and move proximally. Each toe is inspected, the pads are inspected, the gaps between the pads are inspected and palpated. The pads themselves are squeezed in case of corns, which can be very painful, and the digits are manipulated to check for flexion, extension, and collateral instability. The joints of the paws, particularly the metacarpophalangeal joints, can become arthritic and may be swollen, so those should be examined too. Then moving up the limb, each individual metacarpal bone is palpated along its dorsal and palmar surface. The cranial or dorsal surface of the carpus is carefully palpated for signs of thickening, pain, and effusion. On the caudal aspect, the accessory carpal bone is palpated, and then the carpus can be put through a range of motion. In full extension, the carpus should have no more than about 10 degrees of extension, and in flexion, the paw should reach back to the antebrachium. The muscles of the antebrachium are palpated, and coming up to the elbow, the caudolateral aspect of the elbow is palpated carefully for any fluid swelling indicating effusion, as we see here. Effusion is rarely this obvious visibly, but can usually be ballotted between two fingers and palpated. The elbow should flex so the antebrachium goes right up to the shoulder, and both full flexion and full extension should be comfortable, as should external and internal rotation. The canine elbow allows a small amount of external rotation or supination and a much greater amount of internal rotation or pronation. Collateral ligament injuries of the elbow result in much greater rotational movement. The muscles over the upper limb are palpated carefully, particularly over the scapula. Prominent atrophy, as we see here, may be due to a neurogenic cause. Less severe atrophy is probably due to disuse. The shoulder is flexed, being careful not to extend the elbow. And then it's fully extended, again trying to avoid putting pressure on the elbow, and then flexion is performed along with elbow extension to stress the biceps mechanism. This is called the biceps test. The shoulder is also abducted and adducted. When abducting the shoulder, pressure is applied to the scapula to keep the scapula stable. The normal shoulder will abduct to around 30 degrees. The hind paw is examined in the same way as the forepaw, paying attention to each digit and the pads and range of movement of the interphalangeal joints and the metatarsophalangeal joints. Plantar to the metatarsophalangeal joints, the metatarsophalangeal sesamoids are palpated with firm palpation in case of pain, which may be due to sesamoid disease or fracture. The hock is readily fully extended, but note that to fully flex the hock, we also need to fully flex the stifle. The ability to flex the hock with the stifle extended would indicate an Achilles trauma or injury. Fusion of the hock is easiest to feel on the caudolateral aspect between the fibula and the calcaneus. The Achilles tendon insertion is palpated along with the Achilles tendon itself. It should be a thin, taut band in the standing dog with no thickening. The tibia itself and the muscles over it are palpated. The popliteal lymph node can be palpated at the back of the stifle. From behind the dog, the stifles are palpated for thickening, particularly medial buttress, which is a firm swelling over the medial collateral ligament, which is characteristic of cruciate disease. The patellar tendon should palpate as a firm, well-defined band. If it's not well-defined with clear medial and lateral borders, then that's likely to suggest stifle effusion. Medial and lateral force is applied to the patella itself to see if it will luxate. This is easiest to detect when the stifle is extended. The tibial thrust test is performed with an index finger over the front of the stifle is kept still, and the hock is flexed. If there is rupture of the cranial cruciate ligament, then tension in the Achilles mechanism will cause the tibia to subluxate cranially, which will be felt by the index finger. In the conscious dog, this is a much better tolerated test for cruciate insufficiency than cranial draw, which generally requires anesthesia or deep sedation. The stifle should flex such that the hock goes right up to the ischium. Stifle extension should be performed with the hip slightly extended to avoid tension in the hamstrings from causing pain. Pain on full extension can be an early sign of cruciate disease. The hip should be fully flexed. It should be abducted and fully extended. Better to extend hips individually rather than both together. The latter can stress the lumbosacral joint and give you a false positive for hip pain. In the dog with a suspected hip luxation, it can be useful to compare symmetry of the wings of the ilium, the greater trochanters, and the ischial tuberosities, which should all be symmetrical if the hips are normal. Finally, it's useful to assess the dog sitting. You should sit square with the hips and the stifles fully flexed and symmetrically. Often dogs that have a cruciate ligament problem or dogs with other stifle disease that may cause pain in stifle flexion will sit with the legs out to the side like we see here.